As physicians, we seek out mentors to help us out throughout our careers. Some have profound influence despite perhaps limited direct time spent with one another. Dr. Weill has been one of those influential mentors of mine. Our paths crossed when he accepted me to join his team up in Stanford for several months in 2008. He's always been generous with his time. During that few months, things I learned were having a sense of urgency for my patients and their need for transplant, matching patient care with the brand as a business strategy, and even seeking advice from colleagues, irrespective of the years of experience in medicine. And this is a big factor for even as a junior faculty member. It's my great honor to introduce you, Dr. Weill. He's the former director of the Center for Advanced Lung Disease and Lung and Heart Lung Transplant Program at Stanford University Medical Center. He has been a key thought leader in the field of lung transplant and is currently the principal of Weill Consulting Group, which focuses on improving the delivery of pulmonary, ICU, and transplant care. Dr. Weill's writing has appeared in Wall Street Journal, USA Today, Salon Newsweek, and Chicago Tribune, Stat, Washington Post, The Hill, and the Los Angeles Times. His recent memoir, Exhale, Hope, Healing, and a Life in Transplant, came out May 11th. If you haven't seen it, I'll share with you the book cover as well. Today, he's presenting the human side of transplant and the impact of loss and tragedies we face routinely. Welcome, Dr. Weill.
Thank you. And thank you, Kamyar and Mark, for inviting me to speak. I really wish I was with you in person today. It's quite a rainy day in New Orleans, and I bet the weather out there is great. So thank you. Most of the time when someone has a book coming out, the subject of these kinds of talks is about the author. But this is really a talk about you and me, because I think we have a lot of shared experiences. When we're early in our careers, we have education from conventional sources. We've got parents, coaches, medical mentors. But my education, I think, came most prominently, and perhaps yours as well, from the work that we did in the hospital. And for me, that was nearly 3 decades of work on the front lines in the ICUs and in the transplant arena. I used to go home in the evenings and scribble in a little maroon notebook. And ultimately, these scribblings about what happened that day, what I was feeling, became my book that Kamyar mentioned called Exhale, that just came out. But before I tell you any more about that, I want to tell you about an email that I sent my bosses and 150 people at Stanford in June of 2016, letting them know that I was going to leave the program and leave Stanford. And I wrote then that my decision to leave was difficult, and it was, and that it was about many things. And it definitely was. Decisions of this kind are multifactorial. And during the course of this talk, I'll tell you all about what was going on in my mind, and I think you'll recognize some of these thoughts. But before I do that, just a little bit about my own growth phase, so you get a sense of who I am, and I think it'll help you get a sense of how much similarities we probably have. So as Kamyar mentioned, I was at Stanford for a long time. I ran the Center for Advanced Lung Disease and the lung transplant program there. I had all the usual titles that go along with that. I wrote papers, I did some research, probably not enough for the people that employed me, but nonetheless was involved in research, and did all the kinds of things that are associated with these kind of academic jobs. But I think to really find out more would be to say, you know, what is my phenotype, and what is the phenotype of people that do this kind of work? I think hard charging, determined, sure of myself would be all good phrases. Probably, in other words, a lot like you. And why transplant as a field? So we pick these fields that we go into when we're pretty young, right? I mean, mostly in our 20s. And I picked transplant when I was in my late 20s. I found the field fascinating. It was perfect for me. I found it innovative, cutting edge, sexy, really a cool thing to do. And I didn't think about really how it would wear during the course of my career. I was really pretty much living in the moment. And so when I decided that I was going to write down some of these experiences, I brought these ideas to publishing houses and agents. And the first blush was, why write about transplant? There's not that many people that are going to be interested in that. But to me, my book and my writings and the way I think about our field have much more to do with broader themes. It's about getting sick, about getting well. It's about me getting lost and then finding my way again. And it's about life and death. And these are the most universal of themes that are out there. And what we learn doing this kind of work, I think, is probably the most important. I think it also, from a patient's perspective, and I've talked to a lot of patient groups as the book has come out, is I want to get across the idea, and sometimes you probably feel this way as well, that patients are looking at us like we have all the answers, like we're robots, and that every day you wind us up and we go in there and we give this consistent performance. But we have bad days and bad months and even bad years, and this affects how we do our job. And I think that that's important for patients to understand, and we can have that conversation, I think, quite honestly about it. But what about the education? What did I learn doing all of this? I think the first real lesson I learned was about the sanctity of life. And I'll tell you a story about a guy I call Brian in the book, who early on in my career came to see me because he needed a transplant for cystic fibrosis. Brian was developmentally delayed. He had cognitive impairment issues and had been turned down by a number of transplant centers because he was thought to be not able to handle the complicated regimen that is transplantation. And so I brought Brian, I had confidence in him because I met his family, I met him, I thought that we could get it done. So I brought Brian's case to our selection committee meeting, and I know you guys know what that is. That's where we pick candidates for lung transplant. But I also took this as an opportunity to really understand what these selection committees are all about. We're looking at objective data, certainly, but we also make a lot of subjective calls on patients, don't we? We take our own value system and decide who deserves a transplant and who doesn't. And in fact, during this selection committee meeting with Brian's case being presented, someone said it out loud: should we transplant someone that is mentally, and he almost said that word, and then said, I mean, slow or whatever he is, not too many lungs to go around. And it reminded me of the awesome responsibility that we have as transplant doctors, as critical care doctors, and we ought to use this privilege that we have, rather judiciously. I believed in this young man, and I said at the time, life is a life, and we shouldn't put our own, put value on it. So we do this a lot, right? And we do it sometimes consciously, and we do this sometimes unconsciously, but we ought to be careful with that. So Brian, we ended up transplanting. He lived for 15 years after his transplant. He was a model patient, took his medications properly. He and I eventually ran a 5K race together. I'm not going to tell you who won, but it wasn't particularly close. Brian was way out in front of me. And so this is an example that I learned early on about what doing this kind of work can really teach us. But I also learned from another patient early on in my career, a guy that I call George in the book that had scleroderma, was considered too risky for many transplant programs. And we did all the objective analysis of what kind of candidate he might be. But the one thing that I wanted to know, because I anticipated a rough postoperative course, as many scleroderma patients have, was he tough enough? Did he have the right stuff? Was he really going to be able to persevere through a difficult recovery period? So unfortunately, as anticipated, he came out of the operating room quite a mess. He was essentially coding right out of the operating room, and he stayed like that for 2 months. And I know, unfortunately, you've probably experienced these patients too, where every night we had to think of something new to try to save him. But he didn't give up, and neither did I. And I think it taught me that we can dig in with our patients, and we can actually get a lot of these folks through it. And it taught me a lot of lessons about perseverance. So George went on to live 14 years after his transplant. He ran his family's Mexican food business. and ended up he and I staying in touch over all those years until he passed away ultimately. So George was at the beginning of my 20 years on the transplant front lines. My best was on display. I was committed and dug in, and I saw what somebody like George could really do, and that anchored me to the field. He became my star pupil, and I was hooked on transplant really for life. There's also opportunities in what we do to think out of the box. And I'll tell you a story about Ken. Ken was a 50-year-old guy with idiopathic pulmonary fibrosis who got a double lung transplant when I was at Stanford, did beautifully, came out of the operating room looking great, except he didn't think so. He thought he was doing really poorly, and we couldn't get him off the ventilator. I had to tell him, I think your lungs are fine and that you need to focus on taking a deep breath. But he kept on writing on a clipboard in the ICU that he wanted to die, that he thought he was doing terribly. And it appeared that the problem then wasn't with his lungs, but with his head. And so despite all of my coaching and my usual transplant pep talk to him, he wasn't buying it. So I had to think of something new. So the next conversation I had was not conventional, was out of the box, and I think was something that I had never done before, but that I had to do in this case. And I got pissed off. And probably some of you might have done this in the past, where you have to open up the old school can if you catch my drift. And so he ended up then getting mad at me. The nurse, of course, at the bedside was mad at me. His wife was mad at me. But we got him through it, and he got off the ventilator and out of the hospital. And sometimes the ends do justify the means. And I got a beautiful note from his wife later indicating that, you know, we were mad at you at the time, but you did what you had to do. And so that was one of the best feelings in the world, is when you step out of the box a little bit and you get somebody through it. And so he left the hospital breathing without oxygen. He's actually still alive. I talked to him yesterday. He had read my book and he dropped me a note, which was nice. But probably the most important thing that I learned about was fatherhood. And Amanda, who I call Amanda in the book, was a patient we transplanted at Stanford who got a double lung transplant, redo operation, and was supposed to be out of the operating room early one morning, but it was 3 o'clock and I still had no word from the surgical team, and all of us know that's not a good thing. So it was a bad start leading to a bad finish. She came out very sick, was essentially in hemorrhagic shock for 24 hours, and she wasn't going to make it despite our trying everything. So I had to go have a conversation with her family and with her parents to tell them this news. And these conversations are crushing. And I know you've been involved in them, and it's the most difficult part of our job. But what surprised me the most is after telling her father that she was going to die, he wanted to know if I was okay. He followed me down the hallway, and he was about to lose his only child. And I had children of my own. And I know that that must have been the most devastating thing to him in the world. But he actually was showing enough grace to wonder how I was doing. And it reminded me that this is an incredibly precarious situation, and we're a part of that. And demonstrating this kind of grace is something that I think that we all, should aspire to. But at the time, I considered her death a personal and institutional failure, and I had difficulty accepting that. I had difficulty accepting these kind of outcomes throughout my career. And it became a personal war against death every time we did a transplant. And I think mistakenly, that we should be able to win each and every battle if we do our job right. So the field taught me a lot of lessons, a lot of good lessons about people and about society and about what I could do. But it also taught me some things that I would say are not so good. And the first was some tough stuff about accountability. So I wrote a piece in the Wall Street Journal about 18 months ago with a provocative title saying that supply of organs isn't the problem in transplant. Got a lot of emails and a lot of social media messages letters to the editor about why I was wrong. I use an example of a 32-year-old mother who was on our waiting list. We had 3 offers for great sets of lungs in less than a week. But each and every time we ran into institutional problems. We ran into problems with our own program behavior. We ran into problems about inefficiencies of our organ distribution system. The first night we got donor lungs offered to us, we had a gun-shy surgeon who had had a recent bad outcome in transplant. The second night, another surgeon had to do an emergency aortic dissection repair, so we couldn't do the transplant that night and turn the organs down. And then the third night, and I know that the transplant folks on the Zoom call will recognize this, the OPO was hot to trot. They wanted to get the organs procured, and we couldn't get a team in place. So these are all logistical and program behavior issues that are avoidable in my view, and unfortunately cost lives. And I think still in our country, we're not holding ourselves in the transplant community accountable enough to use all these organs. So what we were left with then is a dying patient on our wait list. I had to go talk to her and her family, talk to her 2 young children, and tell them why it was not going to work out. So these are some of the frustrations that go along with the field that I think lead to moral injuries of our own character that I'll talk about a bit later. But what was interesting is after she died, the family told me it was God's will. And I began to question if that was really true. And I was so frustrated because I knew that we could have gotten the transplant done, but we didn't. And so I was so frustrated for the first time in my life, I actually burst into tears in the hospital in a medical supply closet across the hall from her room. And I sat there thinking for a few minutes, not only about her kids that I just had to talk to, but also about my kids as well. But I also learned about racial issues. And these issues are prevalent throughout healthcare. We've read a lot about that lately with the COVID crisis. They're also present in transplant. And I'll give you an example, an organ donor named Donald. And I walked down the ICU one night to see a family that was grieving because there was a silly argument, a gunshot wound to the head, and now Donald was a brain dead potential organ donor. But as respectfully as I asked, and I talked to the family about the potential for organ donation, the family decided not to consent. And I couldn't understand this early in my career, how that could be. But this was an African-American family that didn't have any trust. And so while it might have looked like selfishness at the time, this was something else. This was a lack of trust. And it was a lack of trust that had been developed over decades and decades. And most notably, from the Tuskegee research study that I know many of you are familiar with, a syphilis study where there were untreated African-American study subjects even after we knew the therapy worked. And so we in the medical field have tried to forget about things like that. We've tried to move on from it. But our patients of color have not moved on from that. And so this was an example where transplant intersects with these kind of societal and healthcare issues. And because of that, I wasn't going to be able to get my patient transplanted, at least not that night. Good lesson for me. And I also learned about the role of privilege. My father, when he was in his late 60s, developed hepatitis C, ended up having liver failure and needed a transplant. My father was a pulmonologist, had a distinguished career in academic medicine. And I was at the University of Alabama, Birmingham at the time, early on in my career. I knew the liver transplant folks. I presented them a 68-year-old man with orthopedic troubles and other kind of troubles. And they decided to transplant him. And it made me think about whether or not I'd use my privilege and access to get him transplanted. And knowing that it's a zero-sum game in transplant, one person gets the organs, another person may not, at least that night. it made me really think more broadly about whether or not our processes are fair, whether they're fair in transplant, whether they're fair in healthcare, and is this form of insider trading something that we unconsciously do, but perhaps we should be more conscious of it. So just another lesson. And then what about conflict? So in these high stakes fields that we're in, pulmonary medicine, critical care, transplantation, patients are sick and egos come into it. And in the kind of work I do now with transplant programs, helping them perform better, nearly every poorly performing program has interpersonal relationship problems within the program, that kind of team dynamic dysfunction. And it made me think a lot about conflict, because most doctors, I think, just by virtue of who we are and how we train, are conformists. And so people who try to change things are often on the outside looking in and often on the receiving end of scorn. And that's happened to me in my career. I've been on the receiving end of it, sometimes deserved and sometimes not. But it makes me think about how inherently built in conflict is into our system. And it reminded me of a quote by Aristotle a long time ago, that as we change things, we have to be ready for that. As we try to move the ball down the field and innovate, we have to be ready for this. And at the time, he said to avoid criticism, say nothing, do nothing, and be nothing. And even more recently, Jeff Bezos, not exactly a philosopher, I would say, but he runs a pretty sizable company called Amazon. And he says that if you absolutely can't tolerate critics, then don't do anything new or interesting. And it really made me think a lot about the disagreements that happen in academic medicine and private practice medicine and all really high stakes games in our society. And it made me think that sometimes these fights and disagreements lead to moral injury. And the definition of moral injury, it's a term that's, I think, gotten a little more popular the last year or so with the pandemic, is repeatedly expected in the course of providing care to make choices that transgress our long-standing, deeply held commitment to healing. So this is a misalignment of values between what we want to do, which is heal our patients, and what we actually do when we have these kind of disagreements or poor alignment with our bosses. And moral injury can lead to all kinds of bad things in medicine and in any field: PTSD, substance abuse, depression, anger, conflict with your family because you bring all this home, and then spiritual struggles where you start to question your own faith. So in the midst of all these life lessons, we complicate things more. And we complicate things more because as healthcare workers, we experience all these good and bad things while we ourselves are in the midst of changing. Remember, we pick our specialties and we go into medicine when we're sometimes in our 20s for the most part. And then we expect it to be the right fit when we're in our 50s and our 60s, as I approach my 60s. And it's an interesting thing to consider because we have a life outside the hospital. For instance, for me, it was 2 daughters. They were growing up and I was missing a lot of it, working a lot in the hospital, taking care of other people's daughters and other people's family members. I also mentioned that I was in the transplant field, and my father receiving a transplant made me unable to look at the job the same way anymore. It wasn't just a clinical exercise, it was actually a human being on the other side that I was talking to who had a family of his or her own. And then it made me think about death, because my father eventually passed away 12 years post-transplant. And it alerted me to something that I became very concerned about, how we often become anesthetized to death because of the kind of work we do. See it so often that it's difficult to show that kind of empathy and that kind of emotional response every single time. And in fact, when my father passed away, I had difficulty mustering up an emotional response and doing death right, quote unquote. And that became a source of concern for me. I also developed during the course of all of this.
السلام عليكم. ازيك حبيب قلبي؟ تعالى يا فوفي، I'm taking him to school. طيب.
Hey, we may want to mute.
Yes, حبيبي إن شاء الله.
Thank you. There you go. I also developed a serious but non-threatening life condition of my own. I'm fine. I can hear you asking. I'm fine. But it made me realize the vulnerability that we have when we become a patient, when we feel unwell, and it changed the way that I look at the doctor-patient interactions. So time went on and my career went on, and we had a lot of successes transplanting folks at Stanford. Things were going pretty well, but I had developed a lot of the traits that perhaps some of you have that lead to the poor emotional health that I talk about. You know, treating everything as a frontal assault, some arrogance about not so much in the interpersonal relationships, but being able to control outcomes. That's kind of an arrogant way to look at things. Always seeking perfectionism and being busy all the time. And in fact, I read a very important book called Speed that I would recommend to you by a psychologist named Stephanie Brown, who writes about how this kind of speed addiction, not to the drug speed, but to going fast, can lead to us ignoring our own emotional well-being, which I think is important. But in any transplant program, deaths come, and they did at ours at Stanford. But I treated each one as a referendum on me as a doctor and me as a person. And this eventually led to an empathy depletion that was difficult to overcome. So I had faced a reckoning of sorts. Transplantation as a field became very difficult for me because I was focused only on the bad outcomes and not so much on the good ones. And that's something that we should try to avoid at all costs. And this slide points out, and by a quote by Dr. William Osler, I think you're all familiar with him, that this isn't a new problem in medicine. He wrote that in no relationship to the physician is the physician more often derelict than in his duty to himself. This is an old problem in medicine, but one that should be avoided. Lots of conversation out there about this term called burnout right now. I don't like the term. I think it to me feels like that there's a battery that's run out that can't be recharged. It absolutely can be recharged. So I'm not crazy about the term, but it is a shorthand that we've been using, particularly during the COVID pandemic, because what we've seen is provider burnout on an acute level, but I think it's obviously been going on for many years within medicine. But I do think the way that we use vocabulary is important. But nonetheless, having said that, there appear to be very obvious drivers of burnout. I think the first one, and I'm sure you're going to be able to relate to all of these, is a lack of control over our work conditions, whether it be hiring, who our support staff is, scheduling, what we're asked to do on a daily basis. There's time pressures. There's less and less face-to-face time with our patients. There's tons of documentation time. We can thank the electronic medical record for much of this. And there's also, many of us have administrative responsibilities, and we find ourselves in endless meetings time and time again. But I think a very important factor in what's been called burnout is the lack of alignment of values between the physicians and their leadership. And it's around purpose, mission, sometimes around compensation. And I think there's more of a divide now between the people providing the clinical care on the front lines and the administrative leadership than at any time in my 3 decades in medicine. Chaotic workplaces is the final driver. I know that you know what that means. There's practice inefficiencies, there's team dynamics that I mentioned earlier that are sometimes difficult. What's been encouraging, though, has been the COVID response that I see around the country and the hospitals that I work with. And I'll go through these quickly because I know you know what these are. There's a lot of in-person support systems where there's actually psychologists working with the frontline workers. There's decompression zones that are developing in hospitals across the country where you can actually just get away physically from the battlefield, if you will. And I think that that's been great. There's also been the availability of bilingual staff support lines that I've seen be very helpful. And I think the ability to have peer-to-peer interactions that help form a support group for clinicians on the front lines, whether they're physicians or anybody that's associated with the clinical care of these very sick patients. But in all of this, we have to develop our own tactics for the individual, and fostering relationships and making sure that there's personal attentiveness to a spiritual practice. And I don't mean just a spiritual practice in terms of religion. Spiritual practices can be meditation, walks in nature, exercise. And all of these are part of a self-care that I think is vitally important to what we do every day. What about nurse burnout? I've talked a lot about physician burnout. I pulled a 2020 report that I think indicates a lot of what's going on with nurses. And it seems to be, at least with the nurses that I've talked to, both on a national and local level, a lot around staffing issues. And I found this one report from just a few months ago interesting that indicated that having enough nurses actually saves money for the hospital because of less medical errors, falls, hospital-acquired infections, and patient deaths. But I was not heartened to see that based on a New York Times study, over half of the top 60 hospital chains in America during the course of the pandemic, when times got tough financially, decided to lay off or cut the staff to save money. And this is despite receiving government bailout money to help avoid just this kind of thing. And in one of the nurses I talked to, another factor I think has been what happens to the nurse when he or she leaves the hospital. And one told me that it really is moral injury when she leaves the hospital that's bursting at the seams, trying the best they can to save all the patients they meet, and then go to the bars and stores and people aren't wearing masks, and you know the story there. So one nurse and author that I have a lot of respect for is Teresa Brown. She wrote an incredible book called The Shift, by the way, that documents a 12-hour nursing shift. That's one of the best books I've ever read. But she thinks much of the solution is federally mandated staffing ratios. She decided to leave nursing because, as she said, knowing the system cared more about money than patients ruined nursing for her. And I've heard that quite a bit, unfortunately. Back to transplant and burnout, I've always thought of transplant as the perfect field if you want to burn out, which I know most don't. It's the classic controlling the uncontrollable, or trying to control the uncontrollable. Transplantation, that goes for critical care as well, has so many different moving parts to it that it's very difficult to control. But the control enthusiasts among us, and I include myself in that category, try to do it nonetheless. I was heartened, though, to see the International Society of Heart and Lung Transplant in their meeting last month did have a whole symposium dedicated to these burnout and psychosocial issues. So I think that's a step in the right direction. So what is this syndrome anyway? I've made this slide to try to understand it. I think you can just as easily call burnout disillusionment. That's what it is. It's external factors working on the clinician, whether it's hospital politics, the EMR, conflict, or bad policies. They all work negatively, I think, against the provider and make the job untenable. I think there are also some internal factors. There's mental health issues and depression, and there's also this empathy depletion that I spoke out that also is at work as well. But nonetheless, this leads to the highest suicide rate among professionals, whether you compare doctors and nurses to stock traders, first-line responders, police officers, you name it. Doctors and nurses, the highest among those professional groups. And I think a lot of times it really is due to a misalignment of values between the people that are doing the work on the front lines and those that employ them. I think there has been an upside to all of this, although it's hard to see, I think, right now. But I do think the burnt out provider will ultimately become more empathetic when he or she re-enters the clinical arena again, and most do. And I think that that person will understand that, you know, there has to be self-care, and they also have to show as much empathy as they can to the people that they're caring for. I think the other good news is, as I mentioned, the hospitals are paying a lot more attention to this than they have in the past. And in fact, I'm not sure about UCSD, but many hospitals have whole departments now devoted to provider wellness. But I also think it allows all of us to think more broadly about the field and our career and where we want to go. And is the field still right as we progress through it decade after decade? And it's this constant reassessment that I think is important. So let's talk about reinvention. And so I found myself, for instance, having to reinvent myself in my early 50s, and reminded me of a quote by Carl Jung that the doctor is effective only when he himself is affected, and only the wounded physician heals. And reinvention is scary, it's fun, and it takes imagination. And I think that you have to bring all of those different traits to it. Just an example, my professional life now, I mentioned I'm a consultant to a number of transplant programs, helping them through a variety of issues. I find the work rewarding. It actually is in line with my own skill set. I do nonprofit and for-profit company board work that are in the transplant / pulmonary / critical care arena. And as has been mentioned, I write because it's helpful for me to understand as I write. And a novelist, Jerry Stahl, said that if you had to live it, you get to write it. So I think that that's why medicine really needs storytellers. I think it's therapeutic for the writer and for the reader. And I think it can also change the social and economic factors that are impairing our patient care. As I mentioned, I think it also highlights some of the disparities that are present in healthcare. So what can healthcare workers do to stay healthy? I'll tell you what worked, best for me is connectedness. It's connectedness to what I call the 3 F's: family, friends, and faith. I had a lot of people, friends, close friends, after reading my story say, well, I didn't know any of this was going on with you. And I wasn't the kind of person to go tell everybody every day that I was struggling, that the field was beating me up. And I think that I chose isolation. I chose not to talk about it until much later. And I chose that isolation. And I would encourage you to instead choose connectedness, talk it out, stay connected to the things that you care about. And for me, that included going to therapy. And I wouldn't, and I couldn't have given this talk 5 years ago because I thought, and maybe some of you think, that therapy is for the weak. It's for people that are broken, that are perhaps mentally ill. But for me, it's become really like going to the gym. I pay as much attention to my emotional health as I do to my physical health. And I think that that's probably a healthy way to look at it overall. So we're back to where we started. We're back to June of 2016. When I woke up, I decided I had to get an email off to my colleagues at Stanford. It was time to get off my chest what I'd been thinking about for a while. But before I sent that email that morning, I decided to look at the box. And I don't know if you guys have this as well, but I have a cardboard box that sits under my desk filled with thank you notes and pictures and wedding announcements and anniversary announcements that say beautiful things. You saved my life. Your team was wonderful. You're tremendous. All these kind of things that are validating. And, as I wrote in the book, and on some days really floored me. But what got me the most were those ones that we had lost the patient, and the grace that was shown that I described earlier in the talk about what people are able to do in these very difficult situations taught me so much about humanity, and I'll never forget it. So as I sent off this email, and it was a pretty big surprise to the colleagues that I work with that I was going to step out of the game, I realized, and I sat there and said, you know, what did transplant do for me? What did this career ultimately mean to me? And I finally figured out that I had done the best that I could. And that was the first time in my life that I could actually say that. And the transplant as a career made me who I am. I wouldn't be the same, except given what I experienced. I got this education, and I realized how valuable that is. So I stepped out, I did my consulting work, but after a couple years away, moved back to New Orleans, and I wrote in the book, and I hope nobody's offended by my sometimes salty language, I wrote in the book that most people go to New Orleans to lose their shit, and I went back there to my hometown to regain my shit. But I did this for a couple years doing my consulting work, was pretty happy, slept through the night. My family saw a lot of me, but I had the itch to dip my toe back in the hospital arena. And so there were trainees of mine that were working at Auctioner, our local transplant hospital. It's about a 700 bed facility, big hospital system in Louisiana. And they'd been asking me to come in and lend a hand. And so I agreed to, and I woke up one January morning in 2019 and headed back to the hospital. So they had me go through an orientation session, and this was for new physicians. So everybody was a lot younger than I was, in all kind of different specialties. And I had been out of the hospital for only a couple of years, but it could have been 20. They were talking about things that I had never heard before. In fact, they had a chief wellness officer come in and talk to us about how to stay emotionally healthy. And I had never heard that before from a hospital administrator. I'm sure, like many of you, when I first started working in the field, it basically pushed you out there and said, you know, get to it. So having gone through this orientation, I then went to the transplant clinic and was about to see my first patient in 2 years. And I was nervous. You know, even though I'd seen patients all my life, I hadn't done it in a couple of years, and I'm standing outside the clinic room, and I said, this is the part that you do well. This is a piece of cake. It'll just be you, the patient, and their families. Should work out fine. So waiting inside the clinic room that day was a 55-year-old woman with emphysema. So she was getting evaluated for a lung transplant, and we did all the usual things that we do, all the mechanics of getting people on a wait list, when right in the middle of the conversation, a white middle-aged guy walks in the room, and the patient and this guy embrace, they hug, and I wondered who is this guy? Is he husband or friend, or who is he? But he was none of these things. He had her son's heart in his chest. So my patient, the one that needed the transplant, already had experience with transplant. She had agreed to donate her son's heart to this guy, a stranger, a guy that they would be bound to forever. So as I watched them embrace, tears coming out of both of their eyes, they were chest to chest, and I realized this is her tragedy. It was his gain, and then now he was showing his own gratitude. And I sat there bearing witness to this and thinking about how meaningful this career is. And if you'll allow me, and I'm almost done, I'll read a little bit from this section in the book, just so you get a feel for the interaction. I looked for the patient's hand, take hold of it. While she grieved for her son, I told her that I understand the hurt, that I hurt for her. My holding one of her hands, her son's heart recipient holding the other, these are the times. I think to myself, it's worth it. The hospital rules, the egos, the burden of the responsibilities. In these moments, as an observer of the best in people, I get what I need, what we all need, the education of a lifetime. Now I see that. I couldn't as well when I was going through the hospital so fast, moving through life too fast. And as I sat there with this group in that clinic room, people I knew nothing about just a few minutes before, I felt connected. I felt good. I felt back to myself. So people ask me a lot, and they probably ask you as well, you know, what's this job like to do? What is it really like? And helping people get a transplant successfully or working in the critical care unit is great. It's horrible. It's the best job in the world, and it's devastating. And we see all these great things happen. And like you, I've been a part of making some of those great things happen. And this is the stuff that I'll remember for a lifetime. And I often get asked, especially after people read my book and they see the ups and downs of this kind of career, would I do it all again? And I say, absolutely yes, without hesitation. First, I'd have a little bit of ice cream and Netflix and maybe a nap, but I would absolutely do it all again. And I hope you can relate to that kind of connection to a field that we all love. But I'll leave you now, and I think that this is maybe the most important takeaway from the whole discussion we've had today, is go slowly and notice. And I think that if you go slowly, you're going to actually feel more connected to what you do, and the work will ultimately be more meaningful for you, and you'll have a healthier approach to it. So I want to thank you for your kind attention and be happy to answer any questions that you might have.
Thank you so much, David Weill. And we'll open up for questions. Thanks.
I would just say great talk. I saw somebody else post that. So yeah, it seemed like so timely too, because we were just talking about how tired we all are after, you know, this year plus long slog. But, you know, we have to hang in there and keep working hard. So it's just, yeah, it was a great talk. I don't really have a question, but very helpful.
Thank you. Appreciate that, Laura.